So I'd like to get the session started. Hi, I'm Dr. Anita Palapu. I'm one of the internal medicine doctors here at St. Paul's Hospital, and I've been moderating this Own Your Health community forums that are for the public, and we have experts from Providence Healthcare speak to you about topics that they have an expertise and interest in teaching, research, and in their clinical practice. We have these sessions on the third Wednesday of each month, so you're welcome to come each month I should say, and also bring people who are interested in it. And if you have friends or family who can't make it, what we do is we podcast the actual video of each of these sessions. So if you missed previous ones, you can go through to our website and get the information, and you can share it with other people who you think might be interested. The other thing is we would like you to think of your questions during the time that Dr. Kennedy is speaking, who I'll introduce shortly. And Karen will hand out, if you haven't already picked up, these pink pieces of paper for you to write down your questions. Because it's podcasted, I will ask the question on your behalf so that the audio is clear for the recording, and Dr. Kennedy will answer them. So we do have sessions scheduled right up until July, so we hope you can make it. I'll just mention the one next month. It's called Let's Talk About Atrial Fibrillation, which is a very common heart rhythm disturbance that as we age, many people do develop, and so it's an important issue for people to be educated about. And there are interesting treatments that we're doing here at Providence Healthcare for that. So without further ado, I will introduce Dr. Jim Kennedy, and he completed his medical degree in the other side of the country in Memorial University in 1974 and completed his postgraduate training and residency in internal medicine and clinical pharmacology at McGill at 1981. So he keeps moving west, it appears. And his first appointment was as clinical instructor at UBC in 1981 in the Division of Clinical Pharmacology and General Internal Medicine. And he was promoted to clinical assistant professor in 1983 and associate professor in 1991. And in 1989, Dr. Kennedy was appointed as the medical director of the BC Drug and Poison Information Center, and he served in this role for over 10 years. He's also served as the president of the St. Paul's Hospital Medical Staff Association for 2 years, from 2005 to 2007, as well as the position's operations leader of the hospital's program from 2006 until 2009. So Dr. Kennedy, with his clinical pharmacology expertise, can give us a lot of information about drugs and medications over the counter and prescribed, so I hope you'll give him a warm welcome.
Thank you, Anita. I'm not using that. Everybody hear me okay? Good. So pharmacology and drugs. Of course, everybody thinks of drugs as drugs of abuse. But most of my talk will center around drugs as medications. And of course, medications can become drugs of abuse with not too much difficulty if you focus on it. I think we'll be here till about midnight. It'll take me that long to go through all the pharmacology, I think. Of course, I wouldn't do that to you. Left it intentionally a little open at the end so we can talk about lots of different medications and even drugs of abuse if that's your interest. So how drugs work for you and against you. So what I'm going to be looking at is what are drugs, do some pharmacology concepts. It's very difficult to understand your medications when you're taking them, I believe, if you don't understand them. And I have to tell you, one of the nicest things I feel when I do medicine is when somebody looks me in the eye and says, now I understand, if I'm explaining a drug or something like that. It's really nice to see people understand their medications. And unfortunately, we're not all that good at explaining them. Or you're intimidated and afraid to ask, of course. We'll look at what the drugs do, meaning effects and side effects. We'll look at OTCs, over-the-counter drugs, to some extent. And I was going to present some cases, but just one case over a period of time that reviews some of those issues. And then, of course, can't talk about drugs without talking about dependence, tolerance, and withdrawal, i.e. Issues around addiction. Now, there was this physician scientist who around 1540, I say that because the portrait was done in 1540, and he basically, he's been accused of lots and lots of really neat quotes, and I can't resist this one, of course. Poison is in everything. It's only the dosage that makes it a poison or a remedy, and that is everything. And of course, there are some places where the air is poison when you look at some of our polluted countries. So, what's a drug? Well, I got this from Oxford English Dictionary. I didn't want to get a fancy medical definition. So, any substance that meant to affect the physical or mental functioning of a living organism, especially used for the treatment or prevention of an ailment or disease. And it doesn't matter what a disease is and what an ailment is. I think we all know what we mean. Therefore, we're talking about pharmaceutical drugs, or what you might call big pharma. The pharmaceutical industry, the multi-billion-dollar industry that's sucking us all dry, or herbals. And sometimes I use the term, I've never heard anybody else use it, but I'll use it. How about big herbal? You think big pharma makes a lot of money. You have no idea how much more money there is in herbal remedies than there are in pharmaceuticals. It's geometrically greater. And big difference between pharmaceuticals and herbals is you have to study herbals. You have to spend about $1 billion to evaluate a pharmaceutical before it's considered to be a combination of safe and effective to use in human beings. Whereas you don't have to do that in herbs. I could come out with Dr. Kennedy's wonderful cure for everything. Make a little potion, stand on a soapbox, and sell it to you for lots of money. But you're smarter than that. So, of course, alcohol is a drug. Naturopathic drugs are drugs. Homeopathic drugs are almost drugs because you almost get some stuff. That's just a frail attempt at humor. Caffeine is a drug, nicotine is a drug, marijuana is a drug. Some of these cause dependence, some of them don't. Where do we draw the line? I can tell you that I have been severely addicted to nicotine, and that is some difficult drug to get off of, I can tell you that. So that satisfies all the issues around what is a drug. Lots of different drugs. Now, some pharmacology concepts. I may talk for a period of time about this. Let's look at absorption first. Absorption is how the drug gets in. And the bottom line is, in almost all drugs, we want to get the drug into the bloodstream. Into the bloodstream where it gets sent, unfortunately, to the whole darn body. Okay? Chemotherapy is a really good example of that. The way you kill cancer cells are kind of rapidly dividing cells out of hand. So we give these literally intentional poisons to people to kill rapidly dividing cells in the lung cancer or in the pancreas cancer or whatever. Unfortunately, that drug gets into the bloodstream and kills lots of different rapidly dividing cells. I wouldn't look too much different because I'd only lose this hair. But hair follicles are rapidly dividing cells. So you kill hair follicles, they fall out. As you get better, they start to grow back. Similarly, the lining of the bowel is rapidly dividing cells. They turn over in about a day. So you get an inflammation or bleeding from the bowel, rapidly dividing cells. So unfortunately, drugs go everywhere. They get into the bloodstream, and what we want to do is somehow have that drug have its effect mostly in the cells or tissues where we want them to work, and we'd like them to work little or not at all in many other tissues. So how do we get them in? Take it by mouth, meaning you actually swallow it, of course, like we take most of our medications. And I think it's helpful, actually, to understand what happens then. It gets into our stomach. The drug is carefully formulated, let's say, to dissolve in the stomach because it gets absorbed into the bloodstream through the stomach wall or through the bowel wall. But how does it get to the rest of the body? This is actually important because you absorb the drug from the gut, I will call it. That goes directly into some veins that deliver the drug to the first place that's important, which is the liver. And many drugs are partly broken down in the liver. So I might give 10 milligrams of a drug to take by mouth, and by the time it leaves the liver to get to the rest of the body, it's only 5 milligrams. We've got a term for that. It's called the first pass through the liver effect. So it just means that if you take a narcotic, for example, intravenously, you'll sort of go, really quickly. Gets intravenous, into the heart, up to the lungs, back to the heart, up to the brain, bang, and you feel it really quickly. Take it by mouth, takes 10 or 15 minutes to break down, takes 10 or 15 minutes to get absorbed, half of it gets broken down in the liver, you only get the rest of the half. So rather than getting a curve that looks like that, you actually get something that's absorbed a bit slowly and goes down a bit slowly. So that's the oral route. Sublingual. Ever look under your tongue and see these purple veins there? There's two reasons why we give things sublingually. One of them is that it goes into those veins, into the heart, to the lungs, back to the heart, let's say up to the brain or the rest of the body. It doesn't go through the liver. So we bypass that effect. Oh, and by the way, drug users know all this stuff. They don't need to come here. They know about the first pass effect through the liver. They know that, geez, I can stick it in my eye, I can put it under my tongue, I can inject it in the skin, I can inject it intravenously, I can shove it up my butt. There are all sorts of places to give drugs. One of the myths around sublingual is that if you give it sublingual, it must be fast. And when I talk about distribution, I'll mention why that's important. Giving it intramuscularly, you're basically putting a hole in, or a needle into a muscle that is very rich in blood, okay? You inject it in there. I can visualize a tiny little lake of that drug in between the muscle fibers and gets absorbed relatively quickly into the veins, up to the heart, again bypassing the liver. So if you can get into the veins quickly, you're bypassing that liver. Give it subcutaneously. Almost no blood vessels and fat. So it's going to get absorbed significantly more slowly because it's not rich in blood vessels. Intravenous, have you ever had a procedure? One of those real nice things we do to people, like a colonoscopy. I've had the pleasure, unfortunately, of a dozen or so of them for reasons that are not relevant. And boy, is it ever amazing. You know, you're laying there and they put this thing in your mouth if you're getting a gastroscopy, and the next thing you know, you're in the other room and it's all over. But you can feel a little bit of coolness in your arm and then boom, gone. Very impressive. And safely gone, I might add. There's a little gadget they use that really improves the safety of these potentially dangerous drugs that we're giving intravenously. This little finger oximeter constantly measures the oxygen in your blood so that if they happen to give just a little too much, oh geez, I forgot Kennedy was such a small guy, I gave him too much, the oxygen saturation goes down a little bit, they breathe for me for 5 minutes and it's over and I'm fine. That's a great little device, very comforting when I'm on the wrong end of the bed and getting a procedure. Then inhaled drugs, that's almost exclusively your asthma-like medications, your Ventolin, salbutamol, your inhaled steroids to try to get steroids to the asthmatic lung to decrease the inflammation, rather than taking prednisone by mouth and getting all the big-time side effects. We do get side effects from inhaled steroids. They're just dramatically less. What else was I going to say about... now there's a strange inhaled drug. I don't know if statistically someone in this room will have an oral allergy syndrome. Well, more than one, because I have it. So there's probably 2 or 3 of us in here. Certain fruits, With me, it's raw apples, raw carrots, raw celery, that kind of thing. Cook them and I'm fine. And this is becoming a common issue, only identified in about the last 15 years, perhaps related to improvements in transportation from Florida to Canada and California to Canada, and ripening agents and those kinds of things. That's one of the theories. So if you can't identify what the things are, I know what my things are, so I avoid celery and carrots. No big deal. Some people don't know what it is. You know, 5 times a week, every time I seem to eat, I get itching and swelling in my gums and tongue and up the eustachian tubes and that kind of stuff. So you may have to give some steroid to that area. So again, rather than taking prednisone, you use an asthma steroid inhaler. You puff it, but you actually don't inhale. And interesting, one of the things about inhaled steroids when we use them, we always want to decrease the side effects. Some of the side effects are steroids interfere with the immune system, which is what they're for. So we interfere with the immune system in the lining of the mouth and tongue, etc., and we can get yeast as a side effect with sores and that kind of thing. So with people with asthma, we always say, okay, puff it 4 times a day and rinse your mouth out after. With these people, we don't want them to rinse their mouth. That's where we want the steroid to be. So I only use this as an example of sometimes even we have to be creative with the medications that we use. And then, of course, guide the person about, be on the lookout if you do get thrush. Topicals, salves, steroid, betanivate, things for itching, topical antibiotics, and then there's transdermal. There's lots of transdermal drugs now. There's nitroglycerin that helps you throughout the day with your angina. There's transdermal fentanyl, very potent narcotic that delivers a tiny amount of narcotic through the skin over usually 3-day periods, sometimes 2 days. And nasally, cocaine. That's back in the early 80s. Lots of professionals were snorting cocaine, taking advantage of the nasal mucosa, gets into the veins, to the heart, bypassing the liver, etc. But there's still other nasal drugs that we use, nasal steroids to help your Otrivin addiction, or your nasal steroid to just help your chronic nasal congestion problems or spring allergies. And there's lots of other places we can put drugs, rectally, particularly in infants or children. And then drug distribution. We can give medications into the cerebrospinal fluid. So we can give them into the eyeball, which I find hard to talk about, makes me queasy. So anyway, distribution, that's where the drugs go. And where they go, from a pharmacology point of view, they go to water, fat, and hard stuff or bone, okay? So we know we have protein, but drugs, they kind of ignore protein. They treat protein as water. So there are chemicals that are very soluble in water. Sugar, I guess, is very soluble in water. Alcohol is a wonder drug from a water-fat point of view because it's very soluble in both, meaning it gets dissolved nice and easily in both water and in fat. This is important because if we give a really fat-soluble drug, a drug that's really easily dissolved in fat or lipid, that would be diazepam or Valium, and we get a procedure, it goes up the arm and gets into this ball of fat real fast. So the brain is, I'll just pick a false number, 90% fat. Maybe it's 95, maybe it's 80, I don't know. So fat-soluble drugs get into the brain quickly. Water-soluble drugs, Ativan is an example, gets into the brain pretty slowly because it's more dissolved in water and not dissolved very well in fat at all. That's where the sublingual comes in. You take sublingual Ativan, oh boy, that must be fast-acting because I put it under my tongue. Oh, I can feel it already. I'm feeling better. Most of that is behavioral, I'm afraid, because you won't get enough Ativan into the brain for about half an hour to be able to feel it. Unless you take 6 of them, then you'll get it in not more quickly, but more drug. So sometimes we'll give Ativan sublingually or lorazepam. It's a benzodiazepine like Valium. Sometimes we'll give it sublingually because it's a convenient place. Or someone who can't swallow. It's a great drug for that circumstance. So that's water and fat. So some drugs get into fat quickly, some drugs get into fat slowly. And alcohol, if anybody drinks just one sip of a 40% tequila or something, tend to feel it pretty quickly. And if you keep seeking that feeling, then you're having another ounce and another ounce and another ounce, and you lose that effect that you're constantly trying to get. That gets into addiction, of course. Bone, drugs don't get into bone very well, and they don't stay there very well. We have a very hard time with our patients who have infections in the bone, and they have to have high doses of intravenous antibiotics frequently for a long time, like every 4 hours for 6 weeks, for example, just to get enough of that drug into the bone to actually kill the bacteria. And here's another point about antibiotics. You get antibiotics to kill that bad Staph aureus in my infected arm bone. You're going to be killing all sorts of mouth bacteria, all sorts of bowel bacteria, nasal bacteria, those in my ear. There's bacteria everywhere, and we need them. They're part of us, especially those bacteria in the gut. So we have to be careful when people are getting antibiotics. And how are the bowels today? Oh, geez, I was up 5 times last night, and it's really burning, you know? We have to be careful that we haven't killed all sorts of good bacteria we know we have, but that so-called bad bacteria have therefore been able to thrive. That's that C. diff. C. difficile or Clostridium difficile. Clostridium's a common kind of bad bacterial class. Difficile means it was really difficile to culture. Okay? When it was first described, it was very, very difficult, and we still don't culture it. Now we measure the DNA or something like that in the bacteria that tells us, oh, yeah, this person has this. Paradoxically, we get to treat it with another antibiotic. And if we are quick enough and careful enough, that C. difficile colitis that someone has obtained because of antibiotics will just go away. So that's one of the difficulties with drugs, is that we often do things in areas of the body that we would rather the drug didn't go to, but they do. Then, of course, elimination. Elimination is basically just how the body gets rid of drug. If it's the liver breaks down stuff. The liver breaks down alcohol to something that isn't alcohol anymore, carbon dioxide and something else. The liver breaks down opioids very well. That first pass effect, again, you're only getting 50% of the drug that's going to the rest of the body because the liver broke it down. And you need a fair amount of liver to detoxify those drugs, meaning you can't have bad liver disease and use the same doses for the same periods of time that we would if we did not have bad liver disease. But it usually has to be pretty bad liver disease to have an effect on the ability to metabolize drugs. And there's the occasional drug that you don't need much liver to get rid of. And the kidney is the place where most of the drugs get out of our body. And if you have kidney failure, of course, then you'll be taking less drug much less frequently. So what do these drugs do? Remember I mentioned how much study and experimentation has to go on with, unfortunately, animals and as well as ourselves before that drug is allowed to be marketed. So a drug, basically, we have carefully measured amounts of drugs that have been tested to give a desired effect with most people. It sounds not very sophisticated, but it actually is. Usually that effect that we're looking for correlates fairly well with the amount of drug that we measure in the blood. And there are some drugs that we have to measure in the blood to make sure they're safe, in hospital anyway. That desired effect results from a pretty complex interaction between the drug and very many and varied different cells throughout the body, like hair follicle cells, skin cells, 6 or 8 different kinds of skin cells, a couple of different kinds of muscle cells, 3 or 4 different kinds of muscle cells. Heart muscle is different than other muscle. So all these cell types that make up these tissues have cell surface things that a drug or a hormone can attach to and cause an effect within that cell, and I'll get to that a little bit more. But that's just like side effects. Most often, and for the purposes of this evening, I think it's good to think that usually the toxicity of a drug or a side effect, or commonly I should say, relates to the amount of drug at the site where you're having that effect, or in the blood usually. Sometimes you can get a bad effect from a small dose of a drug. That can be because of how the drug works and you're just made up to be very sensitive to it, or it could be allergy, which is a different kind of side effect. So we pretty well always tell people, oh yeah, and of course there's a small chance that you could be allergic. And we have to be careful when we talk like that because it might be the kind of drug that maybe in 30 years I've never seen an allergy and never heard of one to it. But prednisone's an example. I have an allergy to prednisone. Oh, you mean it makes you feel bad? Or it makes you, increases your appetite, like it did with me when I took it, and I really needed an increase in appetite. So that was good. But if I was 10 kilos overweight, I would not be impressed with an increase in appetite. I think I was about 20 pounds underweight, so that was a good side effect. And I could also do rounds on the ward in about 2 hours taking prednisone. It makes me really manic. I'm glad I haven't had to take it for about 20 years. So, so we get side effects and effects. How'd that happen? Cell receptors. Okay. Cell receptors.
You went ahead on.
Oh, did I? Oh, amphetamines. Now we'll go back. There we go. I'm sorry. So I was going to make some drawings, but try to think of a cell like that, okay, and a little V in it. And you've got a drug that has a part of it that's shaped like a little V. So that drug floating around, boom, gets attached to that V, does some things within the cell that causes the results that we're looking for or the results that we don't want to see. But it has an effect on those cells. Just like hormones. Adrenaline is a good example, hence the amphetamine coming up. So basically, these cell surface structures allow the drug to attach to them and initiate a response within that cell. That cell may be an important cell within the arterial wall that tells the muscles in the arterial wall to relax, okay? Therefore, your blood pressure might be nicely lower, as Jay Conrad may have spoke about last week or last month. Or it might tell your brain artery with migraine to tighten up, but might do other things too. Could be in a muscle. You take a muscle relaxant. I wish I had more trust in muscle relaxants, but they're called muscle relaxants, and they're meant to allow, let's say, the spasm in my spine, paraspinal muscles, the muscles beside my spine. A muscle relaxant may allow that muscle to relax a bit, and I'll have less pain. Muscles hurt like stink. if anybody isn't aware. It can cause a lot of pain with spasm, with bruising, with whatever. However, muscle relaxants, just as an anecdote, are in my, I guess I have to say, experience. We don't like to use that term too much anymore, but in my experience, muscle relaxants are much better at causing sedation and cognitive impairment and slowing you down than they are effective in actually relaxing a muscle enough to help the pain. And that's where it comes to questions. Questions you need to ask yourself when you're taking a medication. Geez, I got this muscle relaxant 3 days ago. I've been taking it, geez, I don't think it's really helping. Or, what unfortunately, this is just human behavior I'm talking about, unfortunately what a very large number of people do is, well, is it helping? Geez, I don't know. And I feel like saying, why are you taking it? Because that's what it's for, is often the answer I get. So, my little anecdote on muscles. Nerves, we have medications that can calm nerves. Now, there's the big nerve, and there's the rest of the nerves. I'm talking about the rest of the nerves. I guess drugs that might calm brain nerves might be anti-seizure medications, because this is all a bunch of electricity going on, and you want something to just take the edge off that electricity so you're less likely to have a grand mal epileptic seizure. And, but we sometimes use these anticonvulsants, these anti-epileptic medications, to calm the nerve that is causing agonizing nerve pain, like sciatica. And I'll be talking about that briefly in a moment. So sometimes we'll use a seizure medication that is meant to calm brain nerves, and we'll use it to try to calm down the sciatic nerve that's irritated and, frankly, often causing agonizing pain. Nerve damage pain can be very difficult. So these receptors are the same as what are normal transmitters. They can be hormone transmitters. They can be other chemical mediators. There's all sorts of names for these things that chemically communicate from one cell to another. Acetylcholine, norepinephrine, doesn't matter what they are, dopamine, all these things, histamine, these are all mediators that communicate from one cell to another. And so if we think of this next slide, adrenaline, drugs can stimulate or block these receptors. So let's look at amphetamines. So amphetamines, a simple way of looking at amphetamines are just another way to deliver adrenaline. And they also have effects on another important nerve transmitter called dopamine, which is probably why we like to abuse that. We probably don't like to abuse it so much for the adrenaline, so therefore the drug user who abuses amphetamine would probably consider that a side effect, but the dopamine is what makes you feel good, okay? So amphetamines do stimulate adrenaline receptors on nerves, muscles, heart. They can speed up the heart, bowel, cause you diarrhea, those kinds of things, or constipation if it's another drug. A beta blocker, there are these little receptors on very many cells in our body, usually arteries, heart, and lung, that respond to adrenaline and have these beta receptors on them that adrenaline fits into, and we get an adrenaline response. Now, we can block that with these drugs called beta receptors, like propranolol, metoprolol, nadolol, bisoprolol, all sorts of alls. That's one of the things about pharmacology. They try to make it easy for us by making them sound similar. And I find that really helpful. But what is not helpful, of course, is propranolol is indorol, metoprolol is Lopressor, nadolol, I can't remember what its trade name is. It's ever so slightly embarrassing when I'm with a patient and I'm talking, and I know they're taking valsartan, but I can't remember, oh geez, what's the trade name of that? And of course they work with trade names, so I stick with the generic names. Drug therapy difficulties. there's, of course, trying to get the right drug to the right tissue or cell at the right time for the right duration is a very, very difficult thing. That's why we have side effects. Because we might get the right amount of drug to the right tissue and cell, and maybe a little bit of the drug to the wrong tissue and cell, and get side effects. Classic example. An antihistamine like Benadryl or diphenhydramine. We take it to help dry things out in our runny nose or whatever, or decrease the itchiness of an allergic rash. But it has effects on some of these nerve cells that causes us to have dry mouth. Or that woman I saw in the emergency department 30 years ago who came in and she couldn't pee because she took 3 Gravol pills that day, and it kind of paralyzed the bladder. And she's fine after a short amount of time. The drug goes away from the body, and she's back to normal and learns a little bit about drug side effects. Minimizing the effect of the drug at all those cells that you don't want affected, like dry mouth. You don't want to have a dry mouth when you're taking your antidepressant. It's hard enough to take an antidepressant, let alone have a dry mouth. It has to be sometimes the price you pay if the drug is actually helping you. Predicting the responders ahead of time, and I'll give you an example of that. There was a study at McMaster, all these aspirin and platelet studies are done in the blood capital of the country at McMaster. And they were trying to figure out, well, geez, we need to give aspirin to everybody to prevent bad heart attacks. There's not so bad heart attacks and there's heart attacks. Do you know the difference? Not so bad heart attack is, oh, geez, that hurts a bit. I should get that looked at. And it goes away, and you eventually get it looked at, and you've got angina. Then there's the bad kind of heart attack where you're walking down the road and you go, boom, bang, dead. And that's usually because there's a big clot in one of those coronary arteries, and that's how devastating can it be? That's about as devastating as it can get. And of course, I'm old enough to have friends or relatives who have had that happen. So at McMaster, they're trying to figure out, well, if we give aspirin to everybody and study it really well, maybe we'll see that it will prevent some of these big clot things. And they looked at, we look at all these studies with 10,000, 100,000 people, 100,000 nurses or whatever it is, and doesn't look like it helps that much statistically. But some people seem to really be prevented and some people not. So they did a bleeding test. They said, well, let's do a bleeding test. Okay, you bled in 10 seconds, you bled in 10 seconds, you bled in 15 seconds. Oh, why don't we give you aspirin and see if that helps? Or they used other techniques like, we'll do your bleeding time, see that it's 10 seconds, then we'll give you aspirin, goes down or goes up to 30 seconds. Ooh, maybe that's a responder. So what I'm getting at is trying to identify the responders before we actually give the drug is really, really difficult. I don't know if Jake Onrot talked about the number needed to treat. If you've got a really good drug for high blood pressure to prevent strokes, you might need 7 people treated before you prevent 1 stroke. It would be nice if we could only give it to that one person. So that's a real big difficulty about these kinds of drugs that are meant to protect people from disease states. This is a slide of a dose-response curve that I did not finish. What else can I say? I actually couldn't figure out how to do an x-axis and a y-axis with print on it, and so that's why we have this. On this axis, that's, let's call that the response, and on this axis, the amount of drug given, okay? So you start with a low dose of the drug, and you get almost no response. A little bit more drug, a little bit more than almost no response. Get up around here, and now I'm starting to get a response. My asthma is starting to feel better. And as you get up, you give this much drug, and you've got a really good response. The maximum response, I would call it. Give more drug, and you didn't gain much. But what you did gain is a much greater likelihood of side effects. So as this dose-response curve rises, so does the dose side effect curve rise with most drugs. So that's what that's all about. And of course, drugs go everywhere. Talked a little bit about nerve drugs, drugs that we want to have an effect on a nerve. And by the way, these seizure medications that we sometimes use for pain, they don't work very well for pain when there's not nerve damage involved. They might, and it might be worth a try if your symptom is bad enough and you want to try it. Trying it would be, okay, I'm not dedicating the rest of my life to take this medication, but for a week I'll give it a try, and I'm going to evaluate it really carefully. And after a week, you know, your husband says, geez, you've been pretty dull the last week, you know, and you haven't had naps at 2 o'clock in the afternoon since you were 18 years old. What's going on? And yeah, it doesn't seem to be helping much either, you know. So that drug is gone. You know, you did your experiment, you tried it for a week or 3 days, and you didn't find enough benefit, but you did find enough side effect. Those are the questions you need to ask yourself. Drugs go to arteries. The ones we want to go to arteries to help angina, high blood pressure, those kinds of things. Veins for similar reasons, muscles like muscle relaxants, heart muscle. We have lots of drugs that have effects on heart muscle. And heart muscle is a very complicated structure, very excitable tissues, electrically active tissues that are susceptible to misfiring and causing these abnormal heart rhythms that will be talked about next month. Brain, we've got lots of drugs we want to get to the brain and more drugs that we would rather they didn't get to the brain. Well, I was going to say, I was going to say particularly opioids, but that's real dumb because we want to get opioids to the brain where they have their biggest effect, but that's also where they have their biggest side effects. I'm excluding constipation, which is so common with opioids that it's almost not worth talking about, except to be aware of it. Stomach, we have drugs that seem to be really, really good at beating the hell out of stomach acid production and not doing much else. These proton pump inhibitors, hydrochloric acid, H is a proton, so these PPIs that we take for gastroesophageal reflux disease are very, very good at knocking down stomach acid. And they've been around just about 20 years now, and we're still waiting to find big side effects, constantly looking for side effects of that kind of drug that seems to be without side effects. It's not without side effects, but it seems to be. So we'll be continuing to be vigilant with our patients about taking these drugs for decades that may or may not have obvious side effects. Often we depend on you to tell us. Oh, geez, that's not in the book. That actually makes sense, you know. I should write to Ottawa and let them know that. So you can help us out a great deal with educating us about side effects. Of course, some drugs go to the pancreas to increase enzyme production. We have drugs that go to prostate or to the sphincter around the bladder so that us men, as we get older, can actually pee. You know, when you go to a hockey game, don't go in the urinal lineup with the guys with white hair, you know. Go to the one with all the young people there. You'll be out of there in no time. And if you take your Proscar, I think it is, again, I'm not that great with trade names, then after 2 or 3 weeks, maybe your urine flow will improve. Got liver drugs, of course, drugs that go to the kidney. We've got blood drugs, often rejection drugs for transplants, drugs that you'll hear about in a couple of months talking about blood cancers, those kinds of things. So it's good that they can go everywhere, and it's bad because they go everywhere. Okay, over-the-counter drugs. Have to be aware of what over-the-counter drugs are. A very large number of them have previously been prescription drugs. The non-steroidal anti-inflammatory drugs are the new biggies out there. Not that new. Ibuprofen, or more commonly known as Advil, Motrin, Novo this, Apo that. And that's something maybe helpful to be aware of. When you look at the bottle and it says Apo amoxicillin, I don't care about the Apo. That's Apotex, the generic drug company in Toronto, okay? So everything is called apospirozine, apothiazide, apoacetaminophen. So forget the Apo part, forget the Novo part, forget there's all of these prefixes with a dash after it. That almost always means it's a generic drug, which is a good drug. They're cheaper and they're at least 99% as good. So good thing to keep in mind. But the anti-inflammatories used to be prescription, well, we still have a lot of prescription anti-inflammatories. The safer ones are the ones that have been chosen to be over-the-counter where you just go buy them. Ibuprofen is the classic example of that. And most people, most doctors are very aware that these drugs help where there's inflammation or tissue damage. So let me give you an example of that, which I may do later anyway, but an anti-inflammatory, if you have a dental abscess, and I take Tylenol, and of course, a lot of us have had these things. You think, oh, geez, that is really killing me, you know. Maybe I'll take some Tylenol number 1s with 8 milligrams of codeine in it. Oh, geez, it's still killing me. Take 2 or 3 Advil, and I don't say that flippantly. Oh, gee, I can move my jaw now. That's great. It still hurts, but that's because there's tissue damage and inflammation. If all you have is very painful, tight muscles, it's surprising if Advil actually works, okay? And don't forget, whenever we take a drug, any drug, for any reason, there is some degree of placebo effect, okay? We study drugs and how they work and that kind of thing, and we may find out that 35% of people in the placebo group had a good response. So that doesn't mean that it's all in your mind. It just means that maybe it means you're lucky and you're a placebo responder, and that's not a bad thing. So be careful with these anti-inflammatories, asking yourself, do they help? And asking yourself if there's harm. And we'll get to a harm in just a moment. And remember, they're all poisons. The intended benefit has to justify taking the drug, the cost of the drug, and the risk of the drug. And we'll talk about the risk of anti-inflammatories briefly. And I really encourage you to ask the pharmacist to help you understand that. I'm just smiling at myself here. How did that one happen? Now I'm laughing at myself. It's that Newfoundland thing, you know. We all laugh at ourselves. Common over-the-counter drugs. So antihistamines. I really encourage people to read the labels. Don't try to pronounce them, but try to read them and see what's in them, because it actually, I sometimes stand in front of the counter and actually laugh. I think, oh my God, are they ever sucking these people in? It's almost all marketing people. You've got Tylenol plain, Tylenol extra. Why is there Tylenol extra strength? Because it sounds like it's really strong. Because it's 500 milligrams as opposed to regular Tylenol, which is 300 milligrams. And, oh, it's a gel cap. Oh, that must be really good. It's red and it's a capsule, and that's all it's about, people. It's got nothing to do with anything other than that. So find the drug you want, Tylenol, and look for the ones next to it that say acetaminophen, okay? And know that 300 milligrams is plain, 500 milligrams is more, extra strength. And Then you've got Tylenol sinus, Tylenol nausea and vomiting, Tylenol cough, Tylenol cold and sinus. Did I already say that one? I can't even remember them all. Whereas what you could do, if you had enough information, so I'm not giving you a hard time because you just don't have enough information, and that is go to the, oh, sinus. Okay, well, I got a sinus problem here, so maybe I'll take that. Can I talk to the pharmacist for a minute and ask them, what's in this? Do I need this? Is there a cheaper form? Oh, maybe I'll get that, maybe all I need is an antihistamine to dry things out and I won't get so much snot all over the place. Maybe I don't need a decongestant. Decongestants are kind of adrenaline-like drugs, okay? And they can cause adrenaline-like side effects. So if you're really sick and you're really congested and it's really driving you crazy and you take 2 of them and you start to get a little shaky, you probably don't need to get worked up about it, but it'd be nice to learn from it and say, oh, it looks like 2 is too much. Anti-inflammatories I talked about, analgesics. Analgesics are things that help pain. Acetaminophen, or trade name Tylenol, is probably the most common analgesic that we use. It's a mild analgesic. It can help your headache that you get twice a month or something like that. Twice a month meaning not very bad and not very common. And then the anti-inflammatories, as I mentioned, the narcotics, lots of different kinds of analgesics. Antipyretics are like Tylenol, acetaminophen for fever. Hyperpyrexia is our word for fever. We like to use big words so you have no idea what we're talking about at the bedside. I actually prefer using understandable words, to be really honest. Vitamins, of course, laxatives. Not every laxative is what you think of as a laxative. There are laxatives that tell the bowel to do this. Okay? That's a laxative. Take laxatives on a chronic basis, you're going to have to take more laxatives on a lifelong basis if you do that on a regular basis. But there are stool softeners. They just make it easier for the bowel to normally push it through and squeeze it through. That's a stool softener. Just to give you an example, trade name Colace or mental block here. Not bisacodyl is Dulcolax, which is a bowel stimulant that you might take as once only. Colace, nice red capsules, which is the only way they come because it's a liquid inside, is a stool softener. Taking 1 a day is like having just a little glass of water. You got to take 4 or 6 a day for them to have an effect and actually soften your stool. Unless you come to me and say, I took 1 a day and I was magic for the next 2 years. Then I agree and say, yep, lucky you. Most people, it takes a lot more of that stool softener to have an effect than the 1 or 2 that is recommended. Antidiarrheals, antacids, those are like those proton pump inhibitors that really knock down stomach acid, but there's also Rolaids, Tums, calcium carbonate, things that just help the heartburn right now. 10 minutes later it's back, but help the heartburn right now. If you're lucky, an hour later and it's back. Anti-nauseants, I cannot resist mentioning anti-nauseants. Gravol. What's Gravol? Well, there's diphenhydramine, which is Benadryl, that common antihistamine, and then there's dimenhydrinate. Sounds just a little bit like diphenhydramine. It's because it's a couple of diphenhydramine molecules with a theophylline salt stuck in between them. So if you're on an airplane and you want to take an anti-nauseant and you don't want to go and buy brand name Gravol, go to your medicine cabinet and see, oh, geez, there's that Benadryl I got last year for whatever. Take the Benadryl. Works absolutely equally as well. But the drug companies had to come up with something just a little bit different and market it as an anti-nauseant. And guess what? Dimenhydrinate or Gravol, pretty good antihistamine. So if you don't want to walk down to the store and get some Benadryl, you can take the Gravol and it will work just as well as an antihistamine. These are just anecdotes that will go probably right in there and right out there. But it's just to try to help you to be interested when you're buying the over-the-counter drug. Sleep aids. Commonest side effect, commonest? Doesn't matter. Very common side effect of diphenhydramine or Benadryl is drowsiness. Oh, geez. Now, if I could market a drug that would help people sleep and they could buy it over the counter, going to make lots of dough. Let's call it Sleep Ease and put some diphenhydramine in there. So almost all of these over-the-counter sleep aids are classic old antihistamines taking advantage of the side effect of drowsiness. Just, again, little things to keep in mind. Won't talk about topicals. Now, am I going to click this thing the right way this time? Let's try this way. I'll be better. I'll get better. Okay, here's a case. I better pick up the pace. Not pick up the pace. I'm going to stop very quickly, I think. A 48-year-old woman with chronic low back pain. Mild to moderate back pain, occurs on a daily basis, doesn't radiate anywhere, doesn't go down the leg like sciatica, and she can do most functioning, but the pain is really bothering her. When we examine her, she's got if this is the spine, the muscles beside the spine are very susceptible to tightening up whatever the cause of the back pain is. So you might have a disc, but it's the muscles that are killing you. Often, not always, of course. And so all she's got is tender muscles, tight muscles around her lumbar spine. X-rays, plain X-rays, just show a little bit of disc narrowing. You've got a vertebral body here, a lumbar spine body there, another one there. It's the disc that's in between. And rather than being like that, maybe it's a bit like that. So no big deal. If you took 100 people, well, if we took everybody in this room who does not have back pain and did a CT scan, we would find about 30% of you with more than a bit of disc narrowing. Always keep that in mind. So when somebody says to me, I have a disc problem, I go, oh, what do you mean? Well, you've got pain. Well, how do you know it's a disc? So it's important to know those kinds of things. So she takes Tylenol number 3 a few times a week. I just put that in there to let you know that that's probably no big deal. Maybe she'll get constipated on the week that she takes more than she takes on other weeks. It's a combination drug, 300 milligrams of acetaminophen, 30 milligrams of codeine, which is 4 times what you would get from a Tylenol number 1 that you simply ask the pharmacist for, and caffeine. And there are old-fashioned regulations that make it so there are 3 chemicals in there. It's not that we need those 3 chemicals. Caffeine also minimally helps a narcotic work, but pretty minimally. And she takes Advil, brand name for ibuprofen, 2 of the 200 milligram tablets in the morning and bedtime. And so 6 months later, of course we're going to get into side effects. Okay. 6 months later, her back pain's about the same. She stopped a lot of activity, mortal sin. You have back pain, it's really important to maintain as much activity as you can. And try to appreciate that difference between hurt and harm. It hurts, but I'm confident with my discussions with my physician that I'm not doing any harm, so I'm going to maintain my walk around the seawall 3 times a week. So hurt versus harm is really important. She's unfortunately stopped a lot of activity. But she's concerned about some swelling in her ankles and feet and a 10-pound weight gain. So the doctor takes her blood pressure. It's 150 over 95 and says, oh, well, you've got fluid around your ankles and high blood pressure. I'll prescribe hydrochlorothiazide, 12.5 milligrams once daily for your hypertension. This is not a diagnosis of hypertension. We make a diagnosis of hypertension when we see somebody serially, say 3 times, and we get elevated blood pressure that is in a range that needs to be treated with medication or lifestyle or whatever. So what's going on here? So ibuprofen is an anti-inflammatory drug called an NSAID, NSAID, non-steroidal, meaning it's not prednisone, anti-inflammatory drug. And naproxen, diclofenac, ketoprofen, ketorolac, and there's half a dozen more. And I mentioned these medications work best when there's so-called tissue damage or inflammation. They don't work that great with muscle spasm. As I said, unless you're lucky. Because I have people say, well, yeah, does that ibuprofen help? And I'm just waiting for that answer. Well, I don't think it helps. And they say, yeah, it actually allows me to do this and this and this. And I have to agree, because that's the bottom line, what the patient says. Common side effect, common, not just a little bit. Fluid retention and elevated blood pressure. It has effects on kidney hormones called prostaglandins. I won't say anything more, but kidney hormones, of which there are many. And that causes fluid retention and elevated blood pressure. Not 200 over 130, but mild to moderate elevations in blood pressure. So somebody taking 3 medications for blood pressure should probably not take an anti-inflammatory drug unless there is a big justification for that person because of the effects on blood pressure. So how do we avoid this situation? Well, the patient can ask questions, and I think the most important questions you can ask are questions you ask yourself. Is this drug helping? Geez, this is an expensive drug, cost me $100 a month, and geez, it's only taken the edge off. I don't think I can justify that $100 a month. I'm going to stop taking it. It's exactly the same with drugs that cost the government of British Columbia $100 a month. I don't think we should be thinking of that cost with the government, but on the other hand, we should be asking ourselves, does this drug help me enough to justify taking it? Does it take the edge off agonizing pain? If I had agonizing pain, I don't want any part of taking the edge off. I want that pain to get nailed. And I'm not going to get into that. But ask your doctor questions. How likely is this drug to help me with the problem that we're talking about? What kind of side effects do you usually see with this drug, doctor? Is that common or not very common at all? When you look at me, doctor, am I very likely to get that side effect because I'm 85 years old, have marginal kidney function, and I'm malnourished? Of course, you don't ask it that way. But that's the kinds of things that can really play a big role on the effects of the drugs on the body. And ask your pharmacist and ask your computer. Big difficulty with these handouts that are given out, which I completely agree with, but they're difficult. You could get one for a chemotherapy drug and one for an anti-inflammatory, and you think, geez, well, that causes nausea, that causes nausea, that causes vomiting, that causes vomiting, that causes constipation or diarrhea, that causes constipation or diarrhea. And then you're going to say, I'm not going to take any of these drugs, they cause this. I'm concerned as a patient if something causes this 1% of the time, or 30% of the time, or maybe you're definitely going to get side effects for the first week, and those side effects will usually go away. That's what I want to know as a patient, the likelihood of that side effect. Not looking at that sheet and saying, oh my God, this causes everything. Well, nausea is 3% of people, rash is 1% of people, hair falling out is 1 in 1,000, diarrhea is 1 in 10,000, dangerous allergic reaction is 1 in 100,000. So things like that. Don't be afraid of reading those sheets and trying to learn from them, but don't say to yourself, I can't take this drug because it causes those things. Say, is my symptom or the reason I'm taking this drug important enough for me to try it and evaluate it myself in a sense? When I'm taking this drug, I don't care what the doctor says. I'm taking this drug, I want to know what's going on. So I took the drug and, geez, I did sleep last night and I'm not groggy this morning. Great, you know, or whatever the drug might be. And the doctor has a difficult task. The doctor has to look at the whole patient. So look at today's blood pressure, doctor, and ask about the back pain too. And maybe that'll allow our thinking to put the two together. There's a book out there called How Doctors Think. It's a little scary, because how do we think? We think like normal people. That's the problem. If we weren't normal, we'd be better. But we think like normal people and we have behavior. So you come in with, yeah, I've got this swelling and this blood pressure, and you forget to ask about the back pain from 6 months ago. But if you ask it, well, how's the back pain? Well, yeah, it's about the same. Is that ibuprofen you're taking very helpful? I'm not so sure. Well, why don't you stop it and come back in 3 weeks and we'll see what the swelling and the blood pressure is like. So it's difficult for the doctor to make a link between those two things sometimes. And if the medication isn't helping, stop it and then get the best treatment for the back pain. Physiotherapy, maintaining physical activity, relaxation techniques, those kinds of things. I have an expression for people who do things like this: smarter than a rock and dumber than a tree. You know? That's how I'm behaving today. So key questions. Other than the medication, what can I do? Well, why don't you make sure you stretch every day, put some heat on that, and try to stretch it out. The physios refer to that as heat and stretch. In other words, the best medication is no medication. And I'm a drug expert. Best medications, no medication. And then, is the medication helping, and how much? This is helping a lot. Therefore, I am going to tolerate that little bit of drowsiness I get before bedtime and accept that side effect. Or I'm going to tolerate a little bit of difficulty getting up in the morning, perhaps. Is the medication having any side effects? Do I know what kind of side effects are common? And does the drug help enough to justify the cost? Addiction issues. This is about it. And I hope, feel free to ask questions in a few moments about addiction issues. A lot of confusion around this. It's a bit sad sometimes when I talk with a 78-year-old woman who's taking daily narcotic for pain and doing very well. And she said, well, I'm a little concerned about this drug, doctor, because I'm addicted to it, you know. And I said, well, what do you mean? Well, I stopped taking it for a day last month, and I felt really restless and uncomfortable and muscle aching, and I was yawning all day. Mrs. Smith, do you know what that is? That's narcotic withdrawal, okay? It's not very bad, certainly not dangerous, but you are not addicted to this drug. Addiction is a behavioral disease. What you are is dependent on this drug. Let's be tolerant, cross-tolerant, yeah. But we'll talk about tolerance first. You take a drug on a regular basis, not usually a blood pressure drug, usually an anxiety drug or a pain drug, narcotic drug, that kind of thing. And the reduction of drug response over time after repeated drug administration, usually over a period of weeks, or the need to take a higher dose of drug to get the same effect that you had previously before the tolerance occurred. That's a physical and pharmacological phenomenon. It is not an addiction issue. Cross-tolerance, just another concept that you can throw out, except if you're interested. That's when you're tolerant to, I use a common example like alcohol, and you stop alcohol, you might get a little shaky or something, take some Valium, and the shakiness goes away. That's cross-tolerance, that you are tolerant to both the alcohol and to the diazepam. The diazepam would be a good choice in this circumstance. Then there's dependence. You've probably heard physical and psychological dependence. Dependence is getting a little more complicated, a little closer to the issue of addiction. But it's the physical state resulting from the adaptation or tolerance in response to the repeated drug use. Tied in with that is if you abruptly discontinue that drug and get a withdrawal reaction, that is the only evidence you have that there is physical dependence. Then there's behavioral dependence. Sometimes, well, I wouldn't say sometimes, I think we're all susceptible to this. If you take a drug once a day for pain, let's say a long-acting narcotic, okay? You take it once a day. Every morning you get up, you routinely take it. But your doctor doesn't believe in long-acting narcotics, so it gives you a short-acting one. So every 3 hours, you take it. That's drug-reinforcing behavior, okay? Nice and simple. That's why we try to use more long-acting drugs than short-acting drugs. Also, it's easier to take a drug once or twice a day than 4 or 5 times a day. So it's a complicated state of reinforcing behavior, of repeated drug use. Then withdrawal. What happened there? So it's the only evidence of physical dependence, as I mentioned. Withdrawal symptoms and signs result from the abrupt discontinuation of the drug. And those symptoms are typically opposite to what we would expect from the drug itself. Let's say you take a benzodiazepine on a daily basis for panic attacks, and let's say you take a fairly high dose of it, and that calms you, decreases that adrenaline that you're feeling with that panic state. But you stop taking the drug, and I didn't know I could shake this much. So you get an exaggerated response opposite to what the drug does. The drug calms, taking the drug away excites. Cocaine. We see people in our hospital here, of course, who take cocaine, and often lots of it, and that's how they get a ticket in. And I may ask, are you going to have much withdrawal symptoms? Sometimes these people are outstandingly honest with us. And they'll say, oh no, I'll just sleep for 2 days and wake up and give me double trays for food, okay? So cocaine is an adrenaline-like drug, and of course lots of dopamine, that takes away appetite and really gets you buzzy, okay? Cocaine withdrawal is fall asleep and you want to eat all the time, except that you're sleepy at the beginning. So drug withdrawal syndrome does not equal addiction. Keep that in mind. This is the end. Oh, addiction, of course. That's a very complex behavioral disease. So if you're taking an addiction-liable drug, you're taking morphine on a regular basis for pain, and it helps the pain, and you function so much better, that is not addiction. If you have pain and it helps you and it stops working and you take more and then more and then more, and then you discover, oh, geez, I kind of like that. That really helps me zone out. That's a nice thing. That's addiction. Okay. Taking the right drug for the right reason, the way it's prescribed, is not addiction. Use of a drug or drug seeking for the purpose other than it was prescribed, that's or in doses greater than it was prescribed, that's getting into the realm of addiction. And taking an opioid originally given for pain and taken in higher doses because it feels good, that's getting into the area of drug abuse and drug addiction. And you can get into semantic stuff. You could say smoking marijuana 1 weekend a month is drug use, not drug abuse. You might say, well, smoking marijuana 1 weekend a month is immoral, so let's call it drug abuse. So I leave that to yourself. You can call it drug use or you can call it drug abuse, you take your pick. Using it every day and trying to function every day, that's probably getting into the drug abuse range, especially if you're 12 years old and trying to get A's in school. It doesn't work. There we go. Thank you very much. I've seen a lot of people awake. I'm pleasantly surprised. It's very nice. Thank you. Thank you.